Hello, good afternoon, everybody. Greetings from Malaysia. So, my name is Dr. Imran. I'm one of the trainees fellows NEPO from Hospital Kuala Lumpur, Malaysia. So, my presentation today is like a roller coaster. I would like to share one of the cases in our hospital, and I hope the case will get everyone's attention and can interest a lot of discussion. So without any ado, let's waste no time and let's begin our presentation. Everybody can see the slide already, right? Okay, so CAPD treatment is a lifetime commitment, okay, until our patient either they went into renal transplant or they transfer to another modality like hemodialysis. And not all CAPD treatment will be smooth sailing. There will be ups and downs. Things can happen like a complication with infectious, like a PD peritonitis, or they can have a non-effective complication like loss of electrolyte, technical problems with the catheter, or things like a fluid overload. So it's very important for the nephrologist to anticipate and address any issue raised during the CAPD treatment. So let's see the cases that are going to present. So my patient is Mrs. R. She's a 27-year-old Malay woman. Before this presentation, she's not known to have any medical illness. Okay, her family history is not that significant. Her father has ischemic heart disease and hypertension. She is second out of two siblings. The sister and the mother was quite healthy and not having any medical problems. The other important thing about her, she just recently got married about 6 months prior to her presentation. So her first contact to us, basically she presented with history of lethargic. She presented about 6 months prior to presentation. She also complained a non-specific intermittent right flank pain is relating to the inguinal area. She had a history of taking traditional supplementation. This is for the overall well-being. Otherwise, she presented to us. She was the normotensive BP of 134/85. She had a heart rate was normal. She's quite a thin lady with BMI of 19. When further history, she did not complain for anything else. She had no symptom that would suggest connective tissue disease or anything like a systemic diseases or any symptom that would suggest nephrotic or nephrotic syndrome. So this is just an overall picture regarding her investigation result when first presented to us. As what you can see here, there is a grossly abnormal urea creatinine with urea of 25, creatinine of 800 already. She has mild hyperkalemia. There's an obvious hypocalcemia with hyperphosphatemia. In terms of her full blood count, there is a presence of normochromic normocytic anemia. When we take her urine, there is a presence of protein 1+. And when we quantify it, about 413 microgram mole. Okay, so obviously we do a ultrasound for the kidney. But we found that the both kidney already shrunken. This average size about 7 centimeter on the right kidney, and the left kidney about 5 centimeter. Obvious evidence on obstruction. Of course, we send for secondary causes, and then all turn out to be negative as well. So basically, for this lady, very unfortunate for her, she's probably already at the point of the disease. So it could be because of missed-scan or some other undiagnosed, but at this point, there's not much we can do. So the question is now, how would you like to counsel regarding her treatment option? I put up some questions. The plan is to have some voting, but unfortunately have difficulty getting it. But I'm welcome with any opinion from the audience. But the question is, what would be the best option for kidney replacement therapy for her at this point? You can have hemodialysis for better fluid control, or you can do a CAPD for better preservation of residual renal function, or you should focus on the preemptive transplant if you have a suitable living donor. Anyone want to share your opinion? There's no right or wrong.
Okay. Perhaps you could ask one of the trainees. No, you're not on the phone. Perhaps you could ask, sorry, this is Dr. Sinta from Malaysia. I was just wondering if the idea of this is, just to get the trainees to share thoughts and not in a very sort of close that we are. Could I ask perhaps one of the trainees from Malaysia, perhaps? We will ask, come over and just tell us what you think. Come. And then we will try to say, don't feel threatened, please. It's just the experience of speaking up, just expressing your opinion. Okay.
Hi, everyone can hear me. I'm Cho from HKL, training in HKL now. For this session, young lady, and I would think that I would either the CAPD for the better preservation of the residual renal function. If the medication cannot control the fluid overload and the kidney function continue further worsening, if everything here can wait, then I think the preemptive transplant, if a suitable liver donor, is preferable.
All right. Thank you so much. A very good opinion. Okay, so basically for her, it definitely we do think that preemptive transplant would be most suitable for her in terms of long-term benefit, and the outcome is obviously better. But for this lady, okay, we did offer all the options to her. Okay, so when she and her husband discussed about it, she has potential donor, husband, the mother and the sister, but the husband actually a non-Malaysian. So in Malaysia, for non-Malaysian citizens, if they want to donate the kidney, it is possible, but they have to go through the unliving related council first. So it may take a bit more time. So she may not have enough time to do a preemptive transplant. The mother, she agreed, but unfortunately, she's a bit older age. So she's already 65 years old at the time. So we do prefer to have someone young as possible. Her sister, unfortunately, when she asked about it, she was still a bit undecided whether she's willing to be a donor for the younger sister. So in the meantime, patient has agreed for CAPD. So we actually managed to convince her to have the CAPD at the same end, inserted during endoscopic technique done by our produce and the training. So starting her CAPD treatment, she started training at the day 10 of post-catheter insertion. There are some issues initially where there's some dialysis leakage at the day 3 of training, but by the day 5, things have resolved completely. And subsequently, she's ready to start her CAPD. Okay, so the question is, when you look at the result, with ura of 17, creatinine 600, no hyperkalemia, only mild acidosis with a good residual volume, urine around more than 1,500 daily, what sort of prescription would you recommended for her? Again, I have some questions that anyone willing to participate?
We have to ask Dr. Gall to help us. He's one of the Thai trainees to just give a sort of a go at answering this question. Dr. Gall, are you there?
Yeah, just coming. Apologies that so I just finished OPD for the patient, so I just coming. Apologies. But I saw that so many Thai colleagues that coming. So let me start with my fellow. Is any volunteer from Chulalongkorn University fellow for respond to the questions?
Okay. Good afternoon, everyone. I'm the volunteer from Chulalongkorn University. So I think the patient still have the residual renal function. So I think I will answer the B first because I think there is a role of the incremental PD. And I would like to start with the 6 liters. Yes.
Can you introduce yourself?
Oh, my name is Rosanan. Nice to meet you, everyone.
Thank you.
Nice
Thank
to meet you.
The second year fellowship.ค่ะ.
All right, good. I like the idea. So for this session, actually, we actually try to push even further in terms of incremental PD. So what we did actually, we think it would be benefit further in terms of reducing numbers of exchange and perhaps rest day as well. So this is what actually we prescribed for her. Okay, because she got a very good residual renal function, as you mentioned. Okay, she got minimal symptoms, so we decided to put her on 3 exchanges per day. So basically, what we trying to say for this lady, because she still have a good residual renal function, so we decided that it will be benefit better if we do a 3 times exchanges per day plus with 1 rest day. So as you can see, the calendar on the left side of the slide, where we give her a rest day on every Saturday for her. As for the exchanges, she can do the first exchange on 8 a.m., subsequently at 3 p.m., and then again at 10 p.m., and then the fluid will remain until the next morning at 8 a.m. again. So this is what we've done to her. So basically, just going to touch up a bit reason and discussion on why we do this to this patient. So as you can see, if you remember in my previous slide, I mentioned that for this lady, we start her training by day 10 of post-catheter insertion. So, but by definition, this is what we consider early start of peritoneal dialysis. Okay, so for her, from the literature review, there are things that can happen when we do early start peritoneal dialysis. One of the Cochrane review in 2020 mentioned that in early start peritoneal dialysis or urgent start peritoneal dialysis, the most possible risk complication that happen is dialysis leakage. However, there was no increase in risk of other adverse outcome or PD dropout in those patients who develop dialysis leakage. For this patient, the reason that we do this, one is because when she first said to us, she's very motivated, she's very keen to start her PD, and then as mentioned, she's planning for renal transplant in the future. We really want to avoid any insertion of the catheter. So we think that she will be really benefit for early start of the PD. At the same time, in our center, we have the capacity to do a rapid insertion of the catheter as well. And you mentioned before, in terms of the incremental PD, so this is something that's been recommended now. I think the most important or the benefit of incremental PD is its potential in terms of preservation of the residual renal function. That's our focus when we decided to prescribe incremental PD and early start for this lady. So unfortunately for her, 2 months into the kidney treatment, she presented again to us with complaint of reduced outflow for the last 3 days. And when we inspect her PD book, we noted that she has been retaining about 200 to 300 daily PD fluid. Otherwise, she denied any abdominal discomfort and fever, and the PD fluid has been quite clear. She claims she have a good bowel motion at least once a day. So obviously, we do an abdominal X-ray. So what does the abdominal X-ray show, and what do you think? How should we manage this patient? So just another quick polling. Okay. Anyone would like to try? Volunteer? Anyone from Singapore? Any trainees from Singapore? I can show the image again if you like. Selayang Hospital, Malaysia. Anyone interested to join? Zoom?
I think we have so many countries to join us from the Taiwan and Singapore, Philippines, Indonesia, and as
Don't worry, we have more questions.
oh, Charter, do you have any fellow to respond for this question?
Hello. Hi. Can you hear me?
Yes, of course.
Anyone here? Okay. Hi.
Very
Cool.
well.
Yeah. Hi. We have fellows. Dr. Liu, 小英，你有在线上吗？哎，Dr. Liu. Yeah. Okay, so she might not can answer this. Yeah. So maybe later another questions for Taiwan this fellow. Yes.
Okay. Then we move to the other country. How about Indonesia? No. Dr. Afudin, do you have any fellow want to volunteer to respond? Or you can speak Malayu.
B boy, I think. There's a migrated catheter tip in the left upper quadrant area, and I would like to try for laxative.
Okay, that's really good.
Good. That would be my choice as well. So, and then that's what we did for this patient. So despite she's claiming that she had a good bowel motion, but when we look at the X-ray, okay, there is you can feel some stool infection can be seen, especially at the rectosigmoid colon region actually. Okay, so
you have to keep closer to your microphone.
Okay. So actually, that's what we did for this patient, because despite she's claiming that she have a good bowel motion, as you can see on the chest X-ray, there is still some presence of fecal in the rectosigmoid region area. Okay, so move on. So, as how do you manage her? So basically, we assess her clinical presentation at the time. She has no fluid overload, she has no anemia symptoms, her PD fluid influence has been quite clear. And then when we send a laboratory investigation, there was no obvious hyperkalemia or any urgency to dialyze her. So we decided to continue with her laxative triple therapy, where we giving her a steroid lactulose, bosacodil, and a Levin enema to get the bowel to move. Okay, so basically when you have a migrating, a poor catheter flow, the things that you have to think about is possibility of malposition and catheter entrapment or extraluminal catheter occlusion, especially from the dilated bowel. Okay, and also possible intraluminal catheter occlusion as well. Okay, for this lady, basically she has catheter malposition or possible extraluminal catheter occlusion from the dilated bowel. So very unfortunate for her, despite previous treatment with laxative therapy and good bowel motion, she still has a poor flow from the catheter. So we decided to convert her into temporary hemodialysis via right internal jugular catheter, and then we remove the catheter and reinsert again using peritoneoscopy. And then subsequently subsequently her abdomen for 14 days, and then she managed to resume her catheter again after 14 days of post-insertion. All right, so things have been quite smooth for the 2 months after that, and she presented to our clinic again for a routine follow-up, and she's been compliant with the treatment, and suddenly she tell us that she has been missed her for the last 6 weeks. So obviously she did a urine pregnancy test, and it turned out to be positive. So in the midst of getting her into RT and getting her to take APD, sometimes there are things we might have a bit overlooked in terms of this lady. So as you know, Mrs. R is a young lady. She's at a reproductive age. She just recently got married, and she was not really on any contraception or any family planning at all. So now she got pregnant. So at this point, I would like to ask everybody's opinion regarding her pregnancy. So whether you're going to allow her to continue pregnancy. However, we have to remind her regarding the risk of to the mother and the risk to the fetus, and also the need to intensify dialysis. Or you can suggest her to continue the current pregnancy because of the similar risk and the low possibility for the fetus to survive. And again, advise her to extend pregnancy once she undergone the renal transplant. So again, I don't think there's a right or wrong answer here, but I just want to know what others think about this situation. And Indonesia, give a try. Yeah, what will you do?
Any thoughts?
Anyone from Philippines? Don't worry.
I'm not quite sure we have a text from Marjorie Fo. This is for this question or the last question. I'm not quite sure. Sunita, do you see the text message from Marjorie?
Yeah, it was about the others. I need to check this. I think the first question that Dr. Mahdi said was to ask whether we actually had to remove and reinsert the catheter, because we could have manipulated it if you have the expertise. So unfortunately, in our center, we don't really have the ability of interventional radiology to manipulate catheters. At least they're not used to doing that. We ourselves have not been in the practice of doing this. But certainly that is one of the other options. Okay, so just pressing on, because I'm aware we will not finish on time. Dr. Afiatin, can I ask you about a pregnancy in such a patient? Do you have any training or fellows with you or on the Zoom call this afternoon? Would they like to take a try at answering this? What is a normal practice? Would you continue the pregnancy? Okay, never mind. I think we will press on because otherwise we will not finish on time. Okay, I'll pass it back to Dr. Imam.
All right, so I mentioned there is no right or wrong answer for this case. So, but for this lady, actually we allow her to continue pregnancy, and on discussion with and perhaps we have to look a bit on what has the experience from the previous cases regarding a pregnancy in PD. So in overall annual incidence of pregnancy in dialysis is rather low. It's about 0.3 to 2.7% only. And the incident in PD has been even lower in the way that it's been reported. Okay, there's one large US data that looking to the 47,000 women with kidney failure, and then 2,352 pregnancy. It demonstrated the likelihood of pregnancy on PD is lower than hemodialysis. Okay, so there's one literature from EMD by Lim et al. In 2018, where they look at about 54 cases of pregnancy that reported in literature. Okay, actually the rate of successful pregnancy is quite good. About 80% of this pregnancy actually end up with a successful pregnancy. However, only 6 of those pregnancy actually went on into a full-term delivery. But 30% actually end up with a miscarriage. So it's not too bad actually. Okay, but then again, we do have to highlight the possible complication and risk factor that can happen to the mother and also to the fetus. Things like a higher risk of preeclampsia or eclampsia, higher risk of death, and you obviously need to control the fluid volume, blood pressure, solute, and okay, for optimal clinical outcome. And of course, there's a need to intensify the dialysis mother who's renal failure. As for the risk to the fetus, we know that there is a higher risk of miscarriage, intrauterine death, and premature birth among the fetus that from the mother who's on dialysis. So, upon our discussion with the patient and the husband, they decided to continue with the pregnancy. So, part of our management for her, we refer her to a multidisciplinary team. We get our maternal fetal medicine to come and see the patient. We actually refer her to the dietitian. We get our pharmacist to involve with the care of the patient as well. As part of the prevention of preeclampsia and neurotic defects, we put her on aspirin, Clexane, hydrofolic acid, and then we actually changed the PED regime to 4 times aspirin daily with no more rest days. So moving on, her pregnancy progressed quite well initially. During the first week 10 of the gestation age, she remained asymptomatic. She tolerated the 4 times aspirin daily PED. Okay, she still have a good UF from the treatment and still have a good residual urinary function. She managed to maintain her urea around 16. There is a slight incident of hyperkalemia at the time, and it resolved when we reduced the potassium supplement. At week 12 of gestational age, we noted that she had significant weight loss, about 4.5 kilo of weight loss. Further questioning, we realized that the patient has intentionally reduced her oral intake. This is because she had some misunderstanding that when she reduces her oral intake, she can reduce the urea creatinine, and this could actually lead towards avoiding of step up the dialysis. It's not surprising that urea actually came down to 13, but we advise the patient that appropriate weight gain in pregnancy is very important for healthy fetal growth and also the mother overall well-being. So we actually refer her back to the dietitian again, re-advise her again. So at the week 16 of gestation age, she presented, still remained asymptomatic. Her weight has been much better. Her urea, however, increased to 17.3. So at this point, there's a time that we have to explain again to the patient that there's a need to intensify her dialysis. So the question is, what sort of strategy that will be appropriate to intensify dialysis induction? A quick question. Basically, you have options to increase the PD exchange to 5 times daily. You can convert her to a automated PD, or you can convert her to hemodialysis. Dr. B, do you have anyone from your side that can share their thoughts on this question? Dr. B from Selayang.
Dr. Mohamad, because in Thailand we use the different units with the Malaysia. You convert BUN and creatinine 2 milligram per deciliter.
Go back to the slide.
It's about 15 milligrams per deciliter. I think the urea of 17.3 is just above urea load in milligram per deciliter of 50, right? And that's the usual guideline for pregnancy in ancestral.
Sweetheart, we cannot hear you well. Can you move closer to microphone? Sorry.
Sorry, looking at the urea here, 17.3 millimole per liter. If you convert to milligram per deciliter, it's about above 50 milligram per deciliter. So that is, the traditional, if I'm not mistaken, cut-off point that is recommended that we should keep our urea levels below 50 milligram per deciliter for successful outcomes in pregnancy. So the question to the trainees is, what will you do at this point? Because we think that you should intensify dialysis to reach that target under 50 milligram per deciliter. So if you look at the options A, B, and C, can one of the trainees perhaps jump in? And I was going to ask Dr. B to nominate one of his trainees from Selayang. Dr. B? Okay, perhaps Golf, you can nominate another trainee?
So, Dr. Lily, any thoughts from you, or maybe you can pass to fellow one? First year fellow, you want to respond to this question, Dr. Lily?
I would like to answer in order to increase the exchange dose, and my target BUN is below 50 milligram per deciliter. Millimole per liter.
Good. Okay. So, but for me, I would to see. I will explain a bit later after this. Okay.
Wonderful. Why you
sorry.
So I asked you
Okay.
HD or transfer to HD. Why you try to intensify like NIPD or CCPD, something like that?
Okay, sure. That's what my next few slides going to discuss about. So actually, there's mentioned before, there are case study of successful delivery while patient maintaining on low incident of pregnancy on PD. Most data regarding pregnancy are very scarce at this point. Okay. So actually, when I went through a lot of the recommendations and guidelines, most authors and guidelines actually recommended for us to switch to hemodialysis prior to the conception or during the first trimester of the pregnancy for those patients on PD. This is the guideline that I so that actually one of the reasons that we decided to change into hemodialysis. The other reason is because pregnant, with insulin failure, because we know that it leads to a better in terms of blood pressure control, reduce the risk of polyhydramnios, there's an increased birth rate. At the same time, it improves maternal nutrition and chance of the life. Those without any residual kidney function, we should aim around 36 hours per week. Those without any residual kidney function, with those with a good residual kidney function, you should target blood urea less than 16 or millimole, or even low as 12.5 millimole. So in what we realized that if patient going to stay on the PD instead of converting to hemodialysis, there are.
So Marjorie, can I ask your opinions on this case to change from PD to HD because you are expert and have a lot of experience about the PD.
No, I think two things about changing to PD is lack of space. If you can get enough clearance, okay, with PD, then continue with it, and as long as it doesn't compromise the the filling of the tummy, and then the patient lose weight, no appetite. But usually when they reach second trimester or when the womb is already big, then usually you have difficulty doing PD for these patients. So at the end of the day, maybe like third trimester or second half of trimester or second trimester, you may have to change to HD if you cannot reach target with PD.
So which target that you anticipate?
I think you mentioned earlier, right? You keep your urea as low as possible, probably less than 15.
15, okay.
Less than 15, and then hemoglobin. There's no really like kind of a target that you have in a sense, but we really don't know what's happening in the fetus, right? In that kind of setting. Is there any evidence? Not yet. I mean that, yeah.
Well, so are you ready? Because you is disconnected, so that I asked Dr. Majoli for the opinions. Dr. Muhammad, do you hear us? I'm not quite sure. They are still.
I mean, while you're trying to get enough adequacy for dialysis or PD, you could change. You can have all sorts of variation. You can have APD, and then, you go change from CAPD to APD, and then with last fill, and try and do as much as possible. If you really want to do PD,
Yep.
I think it can be achieved. It's just a very intensive.
And did you have any success in PD story for the pregnancy? Yes.
What was the question again?
Do you have any term pregnancy success in term deliver? I'm not quite sure how to explain, but any success story for the pregnant patient with PD?
No, usually most of ours, when they get transferred to hemodialysis in the second trimester, because there's just no space.
Thank you. Lily, for Sunita, do you hear us? You need to unmute yourself. Dr. Muhammad, you need to unmute. Yeah.
Sorry.
Okay, we're very sorry. Our internet is very unstable. So thank you, Dr. Madri. We heard your comments, and I think it's true that by the second, third trimester, it can be difficult because of the increasing size of the uterus, as in shown in one slide. It can be difficult to actually increase the PD adequately to reach.
Your signal still not good. Sunita.
One of the other things that people talk about is that time may also be helpful, but not clear. Okay, is that better or not?
Now it's better, but it's like intermittent interrupt, like a swinging of your sound, up and down, like that. Like a patient story, up and down.
Noise, is it?
Apology. The internet here seems to be rather unstable. But I think what Dr. Maji was commenting just now is very true, and that in the later stage, you said.
Yeah.
Sorry, can you hear now?
Yeah, a lot better.
Can you hear now? Yeah, a lot better. Okay, all right. No, just to our apologies. Our apologies. We're now getting. Imhan, you have to get yours. Is it better?
Yes, it's
Okay. It's still echoing, right?
So it seems that you have to close one microphone.
Yeah.
Okay, so everybody has to close this. Nobody's is open. And Imran, you just mute. Okay, so I'll turn this off.
Oh, you need to close one microphone because the my technicians told me that you have to
Yes,
to
okay. Is it better now?
Mm-hmm.
No.
Okay. Okay. Let's try again.
All right.
Okay, good.
Okay.
Okay.
There's a bit of a lag, but never mind. I think what Dr. Marjorie's comments is correct about the difficulty of achieving adequate PD as the pregnancy progresses. And you can try to manipulate the exchanges. But as you see in the last line on this slide, some of the reported literature says that patients have to stay on cycler for up to 18 hours, sometimes with additional daytime exchange. So really what is needed is a shared decision making with the patient. If they really want to stay on PD, they're going to have to be prepared for this sort of intensive therapy. Okay, so over to you, Imran.
Sunita, it seems that you open one speaker and you talk with the other speaker, so you need to close either of them. You cannot talk with one microphone and open the other speaker. Just use only one access.
Unfortunately, we have a problem. We had a bit of problem with our current phone just now. But can you guys hear me now or?
This access is the sound is not clear, but Sunita the Sunita sound is better, but have echo. So you need to close your Dr. Muhammad, and you use the Dr. Sunita access.
I think what.
I'll move the slide.
Okay. Give me a sec.
So can we move on to the other slide?
Yes, good now. Good.
Okay, that's better.
Yes.
Sorry about all the hiccup. Okay.
That's all right. Move on.
Can we change the slide, please? Okay. Can you change the slide, please? Nhi, can you move the slide, please? Sorry, give me a sec again. No, yeah. Sorry, other people can hear me, but what you guys cannot hear me?
No. Other people can hear you.
Because you're using your hotspot, so the connection was there.
Computer tak? Disconnecting.
Oh, it got disconnecting again.
Punya slide dalam komputer.
Yeah. Like,
Pun sebagai langsung boleh present tadi.
just
While waiting for the Malaysia signal, so I want to announce that we're gonna keep a case discussion every month. So for the next one, it's gonna be CPC, which are gonna be the last week of June. Supposed to be on the same day and same time in Tuesday. Okay. Yeah, same day and noon time. For next one gonna be my end is a volunteer for present the cases. I will hand out before time. And if possible, so we're gonna forward the scan slide for the fellow to review before times, if it possible. And hopefully that we're gonna use the universal files that you don't have to download software before read the slide.
Can I ask you, Golf, do you have share source in your country?
Yes, we have share source.
Okay.
But even we have, but actually we don't have a law to use the remote treatment. So that's why actually we actually not use common use in Thailand, but we have share.
Okay.
How's now, everybody? Is it better?
Yes.
Yes.
Very good. Just carry on.
Sorry, thanks. Sorry again for the delay. So as Dr. Sunita and a few other attendees mentioned before, there are certain difficulty or we anticipate difficulty to continue CAPD treatment in this lady. So what we decided for her, we have recommended to her to convert into hemodialysis and have another catheter insertion for her. However, the patient actually was still a bit undecided regarding our plan. She expressed her wishes to continue with CAPD with the current regime. We try to negotiate with the patient because we believe that we're going to have problems to intensify her dialysis with PD alone. So we actually proposed the possibility of doing 5 class exchanges,
8 signs of aging,
and also once a weekly hemodialysis regime. Okay, so because she was still a bit undecided, so we plan to see her again in the next few days to decide what we're going to do with her. As I mentioned before, the reason again, we don't think she can tolerate a high dose volume of PD because of she's rather a small lady, she's rather thin, she had a history of leaking before. So that's why we think the hemodialysis is probably a better choice for her. So moving on. Okay. Unfortunately, 3 days later, she presented again to us with blood thin PD effluent as shown in the picture. And then while she came into our unit for inspection, she suddenly had a sudden gushing of PB fluid. We pretty much clear the liquor. We did a speculum examination. It's just a pooling of clear liquor, but there was no bleeding at all. So unfortunately for this lady, this is happening. So we refer her to our gynae team, and then they diagnose her possible inevitable miscarriage. So they decided that she has to go through medical termination of pregnancy. And unfortunately, at the time of presentation, the uric creatinine is actually higher than expected. And they requested by the gynae team that we need to optimize her prior to the procedure. So we have to insert a temporary intramedullary catheter for her. And she actually went through 2 sessions of dialysis before the COP. At the same time, on the day of procedure, we give her IV vancomycin, IV cefuroxime, and flagyl. And good enough, 4 days later, when we flush the catheter, it's still functioning and there's no more blood stain. Actually, she managed to resume her CPD again after the termination of the pregnancy and passing of the product of the conception. We, of course, referred her for the contraception, and she was counseled by the ONG teams, and they actually started on Implanon. So again, things still not going well for her. 1 week later, she presented to us with a severe abdomen pain with a cervix fluid for 1 day. She's otherwise hemodynamically stable. She's not septic looking. Her US from the PD fluid is good, about 1,000 daily. So when we do a PD count, it's about 175 cells, and the predominantly is a polymononuclear cell. So that's the appearance of the PD fluid. So we trace back the actual culture from the placenta, and it turned out to be E. coli ESBL. For this reason, we decided that we have to preemptively start her on IP vancomycin, to an meropenem, and also oral fluconazole as suggested by our PPG while waiting for the actual PD culture result. So it's very important to remind everybody that post-invasive or instrumental gynecological procedure in PD patient, there's known increased rate of PD peritonitis. It's been documented around 26 to 38% of PD peritonitis rate. And this is probably due to the close proximity of the pelvic cavity to the peritoneal cavity. And the most common organism that has been reported is Streptococcus, E. coli, Enterococcus, Staphylococcus, and Candida. So her progression with PD peritonitis, when we start the antibiotic at day 3, she shows some good progress. The PD fluid has become more clear. The cell count actually coming down. The actual culture that we sent from day 0 and day 3 did not grow anything. Unfortunately, by day 6, we noted that the PD appearance become more turbid again, and the cell count has slowly raised up to 140. And by day 8, the PD appearance failed to clear, and the cell count actually has grown into 1,000. Okay, so what's your diagnosis and management? So this is a quick questions. I think I'll just skip through this quickly. So this is basically, I think, the refractory culture, negative PD peritonitis. We have option of removing the catheter, or we can extend the antibiotic period, or we can extend the period with add on another antibiotic for her. For this patient, what we do, basically we decided that the catheter has to go. So we actually stopped the CAPD treatment, and then we removed her catheter. We reinsert the intramedullary again, and then she was commenced on the hemodialysis. After a discussion with the patient and the family, we decided this is probably the end of their CAPD treatment. She decided that she's going to stay on hemodialysis. We have planned her to have an AVS creation, and of course, as I mentioned before, she has been interested in going on with a renal transplant, and she will continue with that. So this is basically the summary of what happened to Mrs. R throughout her 1-year journey in the CAPD. Unfortunately for her, she's developed a lot of complications from leaking of PD fluid. She got migrated Sankoff, migrated catheter. She ended up with unplanned pregnancy. This unfortunate end up with inevitable miscarriage, and subsequently she also developed refractory PD peritonitis. So this is basically the ups and downs in treatment of PD journey. So for the take-home messages, okay, as what we learned from this patient, not all the PD journey is going to be smooth, okay, and of course, for a young reproductive age woman who started on the PD or dialysis, we must not neglect the possibility of pregnancy. even though we know that the fertility rate among those living with cancer renal failure is quite low, but it's not impossible. So an early discussion, family planning, I think can prevent future headache. Okay, and of course, if they're planning for renal transplant, it can prevent a sensitization event prior to the transplant. Thank you so much, everyone.
Thank you for your wonderful cases. So I want to ask you one thing. Do you actually in your PD program you actually counseling about the contraception for the patient who is young, active?
Yes, yes. Yeah, by right, we do counsel patients for contraception and possibility of pregnancy, even though as I mentioned before, there is low probability of pregnancy, but sometimes it does get missed, especially when a patient has a lot of complication or things that happening to her at the same time. So a practice which have been highlighted even from our gynecology and obstetric colleagues, that those patients at the reproductive age, even without those with a CKD like lupus nephritis, we should actively counsel them and remind them the possibility of pregnancy and its possible complication and difficulty.
And how about the sexual activity? Do you advise them how to?
My own opinion, I don't think that we should prevent the patient from having a sexual activity, but I think that what important is to emphasize on the contraception and pregnancy prevention, especially if they are aiming towards renal transplant. So it's in the point that I do want to prevent any sensitization events. But those with CKD, especially those who have more advanced CKD with GFR less than 60, I do think that it's good to remind the patient that they can continue with their sexual activity, but the possibility of pregnancy can make the kidney disease, the disease progression become faster if they got pregnant. And of course, if they're on renal replacement therapy, dialysis, the pregnancy is high risk and it might complicate their treatment. And if the patient willing to go through all the difficulty, I think it should be a shared decision between we as a carer and the patient, that we can support them, but there should be two-way effort, not only from us but also from patients, that they should willing to go through more intensified dialysis, and they must understand that there is certain risks that they have to go through.
Can we have a short time to ask the opinion from the other country about the contraception and also sexual activity for when we counseling the PD patients about this thing? Do you encourage to to get them have pregnant, or you prohibit them, and if you promote them to have a child, so do you have any protocol for sexual activity or something like that? So we're gonna start with Taiwan. Do you have any opinions, or you have any standard protocol for this issue?
Thank you, Golf. Can you hear me, everyone? Yeah. I'm Jata Liao. Yes. So in our country, in Taiwan, actually, we are not actually forbid or to try to avoid the pregnancy in patients under dialysis. But we do have some discussion, I mean, shared decision making stuff, and then tell them that there's a high risk of when you get pregnant, and then you have the mother and fetus will have the problem, struggling to do that. Actually, in my previous hospital, National Taiwan Hospital, we present in the NDT journals a case with a successful lupus nephritis with ESKD and with successful pregnancy. and deliver a child. So there are some successful experience, but normally we do not encourage the patients to have the practice. And for the sexual activity, we don't do anything. I mean, we don't ask them to avoid or encourage it. That's my personal opinion.
Oh, okay. So Singapore, majority, do you have any experience about the sexual counseling, sexual things, sexual activity, something like that? It's a very sensitive issue. Normally, nurse don't dare or shy to speak out and talking to the patient about this issue. Do you have any protocol?
No, we don't have any protocol. In fact, in Singapore, despite how advanced we are, it is still still a very personal question, and unless the doctor asks, the patient seldom volunteer that ask about these things. And in fact, when you tell them, oh, you can still have sex, and they say, huh, they were so happy, and then they it's like they just they kind of given up when you say dialysis, right? But when you tell them you can do this and you can drain out the water, but you have to anticipate things like you cannot be kind of like suddenly want to do something like that, So they get a very appreciative when we bring the subject up. And I think in our current situation, society, my residents are not geared enough to bring that topic up to the patient. And the patient is also very shy to talk about all these things. So I think this is something we have to work on now. You don't have any protocol as such, but every time I see for myself, when I see a younger patient and I would tell them, you just started dialysis, you are still fertile. So if you don't want a family, you better do precaution and contraception. So I think, so this is just the thing that we have. We don't have a protocol, but we do, when we do suggest something, you only have to start. Otherwise, they won't usually say it, I want to do it, that kind of thing.
Thank you for your opinion.